We are back to the green book again. We're going to talk about chapter 5. Don't get stressed out. The chapter looks long and there's a lot of slides, but it's not really as bad as it looks. This should only take about a half an hour. Alright, I don't want to scare you. This PowerPoint looks kind of long, but there's not a lot of information on each slide, so it's sort of unnecessarily long. But let's dive right in. Medication non-adherence is really anytime anybody fails to do what they're told to do as far as their healthcare provider goes. So a lot of things count. I mean, you can, in essence, say that if someone smokes and you've told them not to smoke, then that is non-adherence. It's not adherence to their therapy or not. So it can be really straightforward, like they're not taking their medication, or it can be something a little more abstract. It's actually very common. About half of all patients will be guilty of this at some point, and probably every one of us have been guilty at some point or another. Even if it's something as simple as not completing a course of antibiotics because you feel better, it happens all the time. It's really a big crisis, and we know that the less education someone has, the more likely they are to not adhere to what they've been told. They're also more likely not to go back for refills, and they're not as likely to see a physician for follow-up care. They're also not as likely to have seen a specialist, so they're more likely to have seen the wrong type of doctor for what's wrong with them. You know, one of my favorite things to ask respiratory patients is, who's your pulmonologist? Because it's shocking how many of them don't have a pulmonologist. So there you go. Their GP may be doing the best he can to take care of them, but if they were going to a pulmonologist for their respiratory problem, they would probably be in a better situation. We can classify medication non-adherence in a lot of different ways. It can be related to the prescriber, the patient, the medicine, or the pharmacy. And I'm sure there's a lot of other variables we can put in there, but these are certainly the most common. If it's the prescriber, then either they didn't give you adequate directions, or they chose a medication that insurance didn't cover. Maybe they didn't give someone enough medication, that kind of thing. It can be pretty frustrating. If it's patient related, it could be as simple as someone's really forgetful. This is particularly bad when they get older and they have dementia. Sometimes they just shouldn't be taking care of themselves alone. Other times the patient might not like the medication. Maybe it has side effects they don't like, and so rather than going back to the doctor and saying I don't like these side effects, they simply stop taking it. Or they're embarrassed because the CPAP is loud at night. There's that kind of thing. Sometimes the pharmacy is out. I'm sure everybody's experienced that. I certainly have, where the pharmacy either doesn't have what I've been prescribed, or they will do automatic substitutions. Sometimes that goes over well and other times it doesn't. But you really should try to figure out what caused a medication non-adherence so that you can fix it. You can't fix it if you don't identify it. Adherence and compliance are the extent to which the patient complies. So they sort of go hand in hand. If they're adherent, then they are also compliant. And then they can be non-adherent and non-compliant. Kind of, we use those terms a bit interchangeably. It can be intentional or unintentional, this non-adherence. They might be doing it on purpose. And again, it might be something like they just simply forgot to take that pill today, or it makes them really ill and so they just decided not to take it at all. So there's a lot of different possibilities here. So again, here's part of the list I was mentioning earlier. If the initial pills were not filled correctly, or if you didn't get enough of them, that's not uncommon. A pharmacy has 20 pills on hand, but your prescription is for 30 pills, a pill a day. So the pharmacy may not give you a full prescription. That necessitates a second trip to the pharmacy from the patient, and it often is a second copay for the patient. This can be particularly annoying because medications can be pretty expensive. So, for example, I have a copay for my prescriptions. Not many people do, but I have to meet a deductible in addition to the copay. And so when my insurance turns over at the beginning of the year, it's not uncommon for a prescription that in 6 months will cost me out of pocket maybe $40 to be several $100s. I went to get a migraine refill. They were giving me 9 pills, and my initial copay right after the insurance turned over, so with the deductible that I had to pay, was going to be $600 for those 9 pills. Now later on in the month or in the year, I'll get those same pills for $40 or $50. So sometimes it's timing. And then there's insurance issues. So there are different things we can do, or people do, to make their medication last longer. They skip doses, they break pills in half that they probably shouldn't. They make them last longer one way or another. That's not good, but that's what people do. So again, the typical non-adherence rate is somewhere around half of all patients are non-compliant. And of course, it makes perfect sense that the higher rate of people who are non-compliant are people with chronic problems, because number one, they just get simply tired of taking their medication. Number two, they're sick and they don't feel well, and they're more likely to forget their medication. Number three, they can't necessarily afford all of their medication, particularly if they have several different prescriptions prescribed for the same problem. So there's lots of different things that go together when you have chronic problems, and therefore chronic therapy, that will make those patients less likely to be adherent. In third world countries, there's a much higher rate of non-adherence, and that makes sense too. Most of that is directly related to access to medication and access to health care. Here's a little list here: asthma, depression, where you can see which people are more likely to not adhere to their therapy. It's really directly related to how much your condition affects your daily life. So that 30 to 60% for depression, there are people who are not so depressed and people who are much more depressed. And if they really get a lot of benefit from the medication, they're much more likely to be adherent. So if one antidepressant doesn't work, it's certainly worthwhile to try another one, because you might get some traction with the second one. Same thing with epilepsy. If you don't have a bad case, if you have a mild case of epilepsy, mild hypertension, mild asthma, you're less likely to be adherent, or you're more likely to be non-adherent, same thing. So there's a lot of, it depends, there's a lot of gray area in this. Non-adherence can certainly cause increased mortality and morbidity, and it can really affect your quality of life. That's what the QOL is over there. We know that 69% of the patients who are hospitalized for medication-related problems, which you can read as a chronic condition, those are non-compliant people. So if you have a chronic condition, diabetes or asthma or hypertension, and you are not compliant with your medication, you are at a 69% higher risk of being placed in the hospital. If you do the math there, it costs us about $1 billion a year. And it's something that most of us just don't pay any attention to. The World Health Organization says that if you spend the money to try to make this better, to make patients more compliant, then you will almost immediately see your money back and then reap benefits. So, you know, this is sort of a backwards thing when it comes to the United States. We don't like to pay for things up front. We're really reactive as opposed to proactive. But in this case, if we were proactive and we really sat down with our patients and educated them about why we are giving them this medication, how to use it, when to change your CPAP mask. If we explain to them that if this doesn't make a big difference in your life, then you need to call us back because we'll find something else that will. If you just keep working at this, eventually you'll find that your patient will become more and more compliant and healthier. So it's certainly a place where we could all do better. You can read through this on your own, but this is how you would detect and diagnose a problem and then treat it, but you've got to prevent it in the first place. It's a nice little circle. So the first step is to detect this, figure out that it's going on, and unfortunately you're going to have to ask patients directly, are you taking your medication? Are you using your CPAP every night? And you know the answer as well as I do. They lie all the time. So knowing they lie, if you can deal with them in a really non-confrontational manner and maybe joke around a little bit and just say, you know, Mr. Smith, I'm pretty sure you're not using that CPAP every night, because we would see better progress with some of your other problems. So why don't you just tell me the truth and we'll keep it between us? Which of course then you promptly write it in their chart. But I think you get the picture. The next thing you have to do is quantify your problem and classify it. Figure out if it's something that happens all the time or just sometimes. If they skip wearing their CPAP mask once a month because their face just needs a break, it's probably okay. That's not a hill worth dying for unless the patient super truly needs that one day out of a month. If, however, they're not wearing their CPAP mask 5 out of 7 days, then that's a problem. So you've got to figure out how bad your problem is and then what caused it. Is it a problem with the prescriber, the prescription, the pharmacy, the doctor, whatever? And once you figure out what the problem is, then you have to decide if the patient's really ready to change. And this could take some work on the patient's part. I'll let you read through this, but here is a list of specific prescriber, patient, medication, or pharmacy-related issues. Once you figure out the problem and how bad it really is, then you've got to come up with an action plan to fix it. I'll go back to what I said previously. Autonomy, autonomy, autonomy. Bring your patient in to this discussion and have them help you figure out a way to deal with it. You could use some simple technology. You know, there's the pill boxes that are marked Monday through Friday. There are even larger ones for a whole month's worth of pills or 2 weeks worth of pills. You could have those set up and just tell people, you know, fill up the box at the beginning of the month. Or if it's an elderly patient, have their caregiver do it, or a child. You can set reminders on your phone. There are a lot of different things you can do to help people remember. But again, if you reinforce the education here and explain why we are doing this, and that if this stuff really isn't helping you that much, then it's not the right stuff, we'll find something that is, well, maybe you'll get more compliance. This is sort of that list rehash, problems with the prescriber. Sometimes a doctor is really busy, or his PA or whatever. A patient goes in to see the physician and they get 30 seconds with them. The doctor does not do a good job explaining why he's prescribing a medication or what it should do, what it shouldn't do. The doctor doesn't do a good job of explaining what the side effects may be. So in the end, the patient doesn't get any education, doesn't get real information that they can use, and then when they don't like what the medication does to them, they give up, they quit. Along the way, they will not trust their doctor anymore. And then the next time he prescribes something, they're just going to toss it out the window before they even get to the pharmacy. So that's a problem. We know that some patients have a lot of different physicians and the right hand doesn't know what the left hand is doing. Part of the healthcare law was to change electronic medical records and consolidate all this information into one place so that prescriber A would know what prescriber B already did. And then they could compare notes and they wouldn't be running roughshod over one another anymore. So right now, you could go from doctor to doctor unbeknownst to them and get prescriptions for whatever you want over and over. At that point, it's really up to the pharmacy not to fill it. And pharmacies are better at catching things like that than the doctors are. A good prescriber will ask the patient a lot of questions. They'll spend some time with them, they'll get to know them, and they'll figure out what their concerns are. And a good prescriber will figure out the best way to give the patients their therapy. If it turns out that a patient comes in a month after they get their CPAP and they say, "Doctor, I really hate this thing. I don't think it helps at all. I don't want to use it ever again." Then if a doctor is really listening actively and willing to help the patient, he's going to say, "Okay, well, let's switch from a full face mask to nasal pillows." You know, they're going to have ideas, they're going to have alternative therapies available, but they have to put some time into this. There are medical schools, I think it's Princeton or Yale. Oh, no, I'm sorry, it's the Mayo Clinic. And they spend a lot of time teaching medical students how to talk to patients in such a way that if you ever see a doctor who's gone to the Mayo Clinic, had their training there, that doctor will make you feel like you're the most important person in the world. They will not ever let you feel like there are 20 other people waiting for that doctor's time, even though that's the fact. They're just exceptionally well trained. They have a great bedside manner. Now, it's very formulaic and it's always the same, but it works really well. The fact is, they're not any less busy than anybody else. They've got 50 patients waiting to see them. They're all stressed out. But they were not allowed to graduate from medical school until they could put on a good show. So in this case, even though it's sort of smoke and mirrors, it goes a long way with patients. And the same thing can be said for respiratory therapists. When a patient gets a new medication or a new therapy, there are a lot of bits of information we throw at them all at once. The dosage, how often you take something, the method of delivery, what side effects they should look for, when they should be concerned, when they should not be concerned, how they know it works, how they know it doesn't work. Lots and lots of information, especially if they have more than one prescription that they're leaving with. So if they come into the ER and they leave with 5 prescriptions, that's a ton of information. On top of the fact that they're sick, they don't feel good, they're probably not processing very well at this point. So letting them leave with not just verbal instructions, but also written instructions is imperative. And in those written instructions, it needs to document how to care for the medication itself. I mean, does it need to be kept in the refrigerator, kind of thing, and possibly how you can tell when it runs out. And I'm talking about, in particular, an MDI. Sometimes, especially those little teeny tiny numbers on the counter, it's hard for people to see them. And as I get older, my eyes are not what they used to be, and it sucks. So if you got an elderly person, you know, hopefully you can say, don't worry about it until you see red in there. Once it turns red in the box, you got to worry about it. Something like that. That's part of the reason they do it. Generally, don't overwhelm your patient. It's pretty cut and dry. If they leave with a lot of stuff, a lot of new medication, a lot of new information, make sure you give it to them in written form, and that they respond to you and tell you, yes, I understand what you just said, here it is, XYZ. That's great, but they're going to forget it as soon as they get home. So make sure you send it home with them in writing, and also make sure they know this is what will happen if you don't take this medication. You know, bad things will happen. Those bad things are, you'll drop like a fly and die. A vein in your head will burst. Your lungs will shut down and you'll never be able to take another breath. You know, you can scare them if you want. Just be honest. Sometimes non-compliance is predictable, and you're going to know it when you see it. If the family is lower socioeconomic in nature, they're not going to see physicians as often. They're not going to be as familiar as with medical care, and they are going to be less trusting of medical professionals. There's also a lot of people who are in complete denial. My grandmother did this. She had a terrible case of COPD, and it's because she smoked 3 packs of Lucky Strikes a day for 60 years. But you know what? When asked, she would tell me she had asthma. She said, my lungs are as clear as a bell. I'm sure they were, because she probably didn't have any lung left. So it's all, that denial of illness is extremely common. And then once they stop denying it, they get depressed and upset and anxious, which in and of itself has been proven to have negative physical consequences. So people who are depressed actually feel chronic pain. They get the equivalent of fibromyalgia, where they have like joint pain all over, and there's no physical cause for that. It's all related to the depression. It's all psychological. That doesn't mean the pain is not real, and it doesn't mean it shouldn't be treated. But in that case, instead of treating the pain with a painkiller, it's better to treat the patient with an antidepressant and take away the depression. So you really have to pick and choose what's going on, what's wrong with the patient, why things are like they are, so that you can better deal with that situation. Again, make sure you send people home with written instructions in their own language with a larger font that adults can see. We typically say stick with the 5th grade reading level. If you don't know, that's the level that a newspaper is written at, and I suppose you could say most blogs these days, most of the stuff you read is written at a 5th grade level unless otherwise stated. So your respiratory textbooks are written at a higher level, but stuff for the general public's consumption is typically 5th grade level. While you're there, while you're talking to patients, ask them what they know about this medication, what they've heard about people who use this therapy, and if they say, oh, nothing at all, okay, good, here, take it and go home. If they say, oh, I heard everybody who uses this gets fat, or everybody who uses this, shoots up in elementary school. This is your opportunity to say, oh, I'm glad that you told me you heard that. Let me set the record straight. But you have to ask that. Very rarely will patients volunteer. Once in a while somebody will volunteer that. But usually you have to ask things like that. What are your fears and what have you heard? And let's take a chance right now to change your attitude. Non-adherence related directly to the medication itself is usually pretty cut and dry. It's either not available or it costs too much money. If a patient is taking more than 4 pills a day, then they are more likely to either forget one or not be able to afford all of their medications, and so something's got to give. They'll pick one not to take anymore. If something has a lot of side effects or the patient's just not comfortable with it, or if it doesn't work fast enough, then the patients won't take it. And if you have to go through a whole sequence of events to use something, like MDI sometimes can be kind of a production where you have to open the blister pack and take out the little pill thing and pop open the lid and put the thing in and twist it and then suck it in. And now, I don't think it's that bad, but to some people that's a pretty complex set of tasks. And so they are more likely to say, forget it, this is just too hard, this is just too much effort. So all the problems that we've discussed so far are pretty easy to fix once you know about them. If the drug you gave them is too complex, like a DPI that I mentioned a minute ago, then perhaps it's time to change to an MDI or some other form of that medication. And let's face it, almost everything that comes in DPI form also comes in MDI form, and that may be less complicated for a patient. We can usually find places to get the drugs for less money. We can switch to generics. We can switch to combination drugs where they have 2 or more medications merged together, so it saves a pill later on. And if possible, just have the patient start 1 new drug at a time. Again, that's not always possible, especially if you have a new onset of something, but I don't know, it can happen. We've all been to great pharmacies and we've all been to rude pharmacies. It's not pharmacy related, it's sort of just retail in general. But if you have a really nice pharmacist that you like and trust, you're more likely to keep going back to the same place over and over. Then you'll get continuity of care. So it's an interesting thing that there's been a lot of evidence that continuity of care in respiratory therapy is important. We know that patients get better faster if they see the same respiratory therapists consistently. The more people you throw into the mix, the longer it takes for a patient to get home. And the same can probably be said about pharmacists. I haven't looked this up. I don't know if they've done this research, but I bet they have. If you trust your pharmacist, they'll go out of their way to help you. They're more likely to call the doctor and get refills for you or clear up confusion on your behalf and not make you go do the legwork. But, you know, there's that. If you go to a lot of different pharmacies, you lose that connection. Some people will tell you that chain pharmacies, we lost that connection, but, you know, I know that some of those chain pharmacies do not treat their employees very well. And that makes for disgruntled employees, which makes for not the best service at the counter. So just, I don't know, beware of all this. And if patients complain to you about any of this, then if you can intervene realistically, then do so. Certainly to get rid of these problems, it's pretty much the same as what you had earlier. You've got to identify the problem and then figure out what the workaround is for it. Have patients carry medications, a medication list with them at all times. Now there are apps on your phone. You can put that in there. There are vials of life you can keep. There are tubes that you can put in the freezer, and you can put documents like your living will, your medication list, any premium medical documents that you want to have nearby. You put these in this canister and you put it in the freezer, and paramedics are trained to go check everybody's freezer. When in doubt, they check your freezer. So if they get called and they find the LOL, which is the little old lady laying on linoleum, and she's all by herself and she can't really answer questions, they don't know what's going on, they're going to check the freezer to see if she has left information for them. I know it's a little weird, but pretty much everybody has a refrigerator or a freezer, so that's where they tell you to put it. It's easy to find. The paramedics don't have to go rambling through your house looking for it. You can just go straight there and find what they need. So it's time to develop your individualized plan now, right? It's got to be reinforced over and over. Every time you see your patient, you've got to, follow up. Are you doing what you're supposed to be doing? Is everything going all right? Are you having any problem at the pharmacy? Is your insurance still paying for your medications? Are you using it correctly? You've got to keep on this over and over. All right, medication non-adherence in the pediatric population happens, but for a lot of different reasons. The children themselves are generally not in charge of taking their own medication. So if there's non-adherence, it's usually a problem with the parents, but not always. Older kids, maybe parents have left it up to them to take it. And sometimes the medication just tastes so bad that no parent could ever, you'd have to sit on your child and pour it down them. And depending on the medication, that may not be a practical solution. Take prednisolone, for example. The oral syrup form of that is some of the most disgusting stuff you'll ever taste. It's horrible. It's horrible. So a little kid will take it the first time, they don't know any better. But if they have a bad respiratory infection, and you give it to them once and they swallow it and they're like, whoa, that was nasty, I'm never taking that again. No matter how much banana flavoring you pour into it, I'm still not taking it. It was gross. Then what are you going to do? Sit on them, upset them more, have them make their respiratory problem worse in order to give them their medication? It's a catch-22. You can't really win. So sometimes it's the parents not doing what they're supposed to. Sometimes the children are not compliant. And sometimes it's really kind of not anybody's fault. The medication's just bad. If you can get the kids involved, they're more likely to be helpful. There are all the problems you have with schools and the rules, what you can and can't take to school. And a lot of times the nurses' aides at schools are just that. They're aides. They're not actually nurses. And frequently they don't have any medical training at all. They're just some lady that the school district hired to sit in the nurse's office and put Band-Aids on kids. So in that case, geez, I think most of the time the children could do a better job by themselves, and yet legally they have to go into this adult who doesn't know anything about their condition or how to give them their medication and watch them suck on their inhaler. Teenagers are a whole nother ball game. They're horrible and they're awful. Between their attitudes and their hormones and their growth spurts, they are more likely to actually have medication problems that are really legitimate. because the dose that worked last week may suddenly just stop working this week. And you'll see them in the hospital around the time they grow. So right around puberty is when any kid with a chronic condition will show back up in the hospital. And it's pretty consistent. You could almost, bet on it and you'd win. They just have trouble when the hormonal changes happen and the metabolism changes. So at least it's expected. With older patients, we have some similar problems, but then some very, very different problems. They certainly have more chronic conditions, which puts them in that category where they're more likely to take 4 or more drugs, which puts them into that category where they're more than likely not able to afford all of their medications. They're more likely to have a complex regime, like this many pills, this, the morning, afternoon, the evening. They also have issues with their vision, as I said before. Their memory might be going. They're more likely to see several doctors who are sort of prescribing. Again, the left hand doesn't know what the right hand's doing. And they also often have trouble paying for all of their health care. So you've got to deal with all these problems and just figure out what's the most important thing and what's the easiest thing to tackle and get taken care of first. In hospitals, there's a social worker at every hospital. Those people are magic, and they can find help when seemingly none exists. They're pretty amazing people. If you've got the older patients, make sure that to the best of your ability you find a caregiver, somebody who can help them out. Suggest those storage boxes I mentioned earlier, and give them written information that's in a larger font. There's a lot of things you can do. Most of it's common sense. So by this time you should be well aware of everything we're talking about here. Just make sure you don't use elder speak, which is the equivalent of baby talk. Don't be rude to these people. Patronizing them will just upset them and certainly not garner support for your cause, which is their medication. Okay, so we know this is a national crisis. If I ask you that question, you should be able to say, yes, this is a national crisis. This is a big problem. And obviously, logically, if you don't take medication, it will not work. That happens 100% of the time. If you don't take it, it won't work. We also have it well documented, it's well known that we're going to have to really attack this problem and use a team approach in order to get past this. Everybody has to be on the same page with all the same patients. So it's a lot of work on a lot of people's parts. Here's a table from your book. I'll be quite honest with you, I have not verified to see that any of these are still useful websites, but I left it here for you for the principle, so that you could see that if these websites are not working, there are absolutely websites out there. There are places where companies help patients pay for their medication. In addition to this, almost every major drug manufacturer has a program in place to help people who cannot pay for their medications. So when in doubt, whatever medication you want to give to a patient, if it's albuterol, you can go to Glaxo Wellcome, and on their website somewhere it should have this information. Okay? Thank you.